So these are the principles that we use to build our resources in CDRC. We're looking at three basic interventions for any sort of problem. We have screening, that's finding people who you don't really have very much information about. There's case finding, that's using the information that you already have to identify patients who've been missed or patients who should be categorized into a certain group. And then you've got providing best care, and that's taking people who have got a particular condition or risk factor and making sure that they have the appropriate management, whether that be advice or referral or intervention or medication. And then we have 4 opportunities to deliver these sorts of interventions. We've got the opportunistic approach where, for example, a patient might present with a cold, and we can take that opportunity to, for example, identify their hypertension. We have routine review, for example, when patients are coming for their long-term condition reviews. We have a more systematic approach where, for example, a pharmacist may take a list of patients who are not having appropriate treatment and contact those patients systematically. And then we have a triggered approach where an event that takes place in the record triggers an action. So, for example, if somebody is prescribed a medication which interacts with an existing medication, an alert can be triggered. And the key thing we try and do when we're designing these systems is make sure they're integrated into what's already been done. When we're thinking about lipid management, we need to think about the whole population. So we've got a group of people with or established atherosclerosis, and we need to make sure that that list is accurate. We need to find the patients who we've missed, looking at that case finding again. We've got patients with familial hypercholesterolemia, and we know that many of those are unidentified. Then we've got the patients who are eligible for primary prevention, and we need to make sure we've identified as many of these people as possible, and we've offered them appropriate intervention. And then we need to take those people who are estimated to be at high risk, who might need to move into that primary prevention category, and make sure that they're offered a risk assessment. This is an example of what we're trying to deal with. So this pathway is the pathway for screening for diabetes and identifying non-diabetic hypoglycemia based on the NICE guidelines and various other guidelines. And no one could possibly remember this or try and implement it without support. So we can take a complex algorithm like this and build it into our existing systems. So when we're thinking about lipid management, we need the tools to do the job, and we've created searches, templates, views, protocols, all embedded into existing systems and workloads. So I'll try and show you how that works in practice. So this is my System 1 unit at my practice. And these are a series of reports that tell me how well we are doing managing lipids. So it's set out in a similar way to the pyramid I just showed you. So at the top here, we can see that 6.1% of my practice has got established atherosclerosis. And then we can see how we're doing in terms of management. So how many of those people are on very high intensity lipid lowering? How many are on high intensity or very high lipid intensity? How many are on lipid lowering at all? We can see that 90% of them are on lipid lowering, or they've got a good reason why not. For example, they've said they don't want it, or they've had lots of adverse reactions. Then we can look at how many of those people have got a target. Well, only a small proportion have got a cholesterol target, and of those people who've got a target, only a small proportion are achieving their target. So there's a long way to go in terms of achieving best practice. This next report is showing you people who looks like who look like they might have had a diagnosis of atherosclerosis missed. For example, they might have a code for a lower limb arterial bypass, but they're not on our peripheral arterial disease register. If we take a search down here, we can see patients who are on lipid lowering for primary prevention, and also those people who are the people who are not actually collecting their medication, who are the people we need to target for encouraging them to restart the medication. So the key things about these searches are they are in real time. So you don't have to wait for a large data extraction and getting quarterly reports. You can see how things are today. It's easy to find. You don't need to log on to any new systems, and the search system is established and comfortable. People know how it works. You can also break down these reports into more detailed analysis if you want to. So, for example, if we wanted to look at the ethnic background of the patients who were in the atherosclerosis group, we could break that down. This system is set to anonymize all information, so it's not actually showing the ethnic categories, but it would normally. We could break it down by age, for example. We could have a look at the age range of the patients. What's most important about these reports is it's not just showing you how you're doing, but it's showing you the patients that you need to concentrate on to improve. So the example I showed you earlier of the patients who are not taking their statins, or the patients who are eligible for primary prevention, but they haven't got not on lipid lowering, and they haven't recorded a reason why not. These searches are updated centrally, so if any changes need to be made, they can be made in one place and they all automatically propagate out. You don't have to worry about keeping things up to date as the end user. But they can also be customized locally. So, for example, if you wanted to know who were the patients, how you were managing patients with learning disabilities relating to their lipids, then you could combine these searches with a local search for patients with learning disabilities and create a more customized version. They can also be used to develop something like a local incentive scheme. So, for example, in our area, in our primary care network, we're encouraging improvements in lipid management. We've created a scheme where we are incentivizing practices to improve their management of primary prevention. So we're encouraging them to get up to 60% of patients who need primary prevention are either getting it or have got a good reason why they're not. So that's this report here. And we can see this is the report showing the practice, who are the patients they need to target. And then we've got a series of sort of gateway reports, which are trying to help with case finding. So making sure that strokes are classified so that they're managed properly, making sure that we find missed chronic kidney disease, making sure that we're incentivizing the practices to record lipid targets. The other major advantage of this approach is that you can use exactly the same system to report at scale. So these are the same reports in a reporting unit covering the practices in North Durham. So we can then see at a much bigger scale, this could be used by a primary care network or a CCG, to see in real time the information across the practices. You can see how that information, if need be, can easily be extracted and analyzed separately. So, for example, this is some of this data extracted for comparing my surgery with the rest of my neighboring practices. And we can see how I'm managing in terms of the proportion of people who are having lipid treatment or have got a good reason why not, or are not having treatment. And we can see how we're doing in identifying those people who need primary prevention. these are the people still left to assess. This is an example of comparing the practices in my primary care network, seeing quite wide disparities in performance. More specifically, just thinking about the familial hypercholesterolemia. So we can see some reports here that we've used to identify patients with potential FH. We've designed a system based on an iterative process, looking at a number of different approaches to identifying these patients, and have come up with our sort of composite CDRC identification search, which is here. But really importantly, you can then subdivide this into people we can exclude people who've already got a diagnosis of FH, whether that be genetic or clinical, or, for example, in this search, patients who've already had a Dutch Clinic Lipid Network score or been to the lipid clinic. So we can make sure that this is suitable for an ongoing audit process, not just a one-off process where we can take people off the list and people can be added onto the list as they become eligible for assessment. Similarly, with tools to identify people who might be eligible for PCSK9 inhibitors, we've got this group of people here who could be eligible based on the NICE criteria, and then we can make that more practical by excluding people who are unlikely to be suitable. For example, people who are terminally ill, people with severe frailty. Then we can take out the people who are not taking their current treatment, because we'd be better off trying to encourage them to take their current treatment. And then we could then take out people who haven't already tried a statin and ezetimibe. So, they probably need to try some of those treatments before thinking about referral for more advanced treatments. So just thinking about how that works in real life. We've got an example here of a patient who has got a number of issues where we might be able to intervene to improve their health. If they were coming for their long-term condition management review, this patient doesn't have any long-term conditions, but we can see that there's a number of interventions that we need to consider here. There's some vaccinations they're eligible for. We need to think about whether they might have undiagnosed hypertension, and we need to be thinking about whether they should be offered lipid lowering. They're also eligible for an NHS health check. So if we clicked on this alert, that will bring up the information we needed to provide the appropriate advice. So we can see that it looks like this person's eligible for primary prevention. We can see that they've had a Q risk above 10% recorded. We can see the recent cholesterol reading. We can see that they don't seem to be on any current lipid lowering medication, and the system's offering us a warning saying, perhaps you should think about offering this person a statin, especially because there doesn't seem to be any record here of us actually offering this person a statin. So if they said they didn't want one, then that's easy to record. If they did say they wanted one, then we can click through to the lipid lowering. And we've got some tools here that might help. So for example, if we click on this, it will open up a Kate's plot showing the patient the smiley faces with their level of risk. And we've got some patient decision aids from NICE, which could be either given, printed out, or emailed to the patient. Let's say the patient agreed to start a statin. We could then use this tool to calculate the target non-HDL cholesterol. I'm not going to do that for a moment, and I'll show you why in a second. And then we could say, I'm going to offer this person a atorvastatin. The system will show us the key interactions, and it'll show us if the patient's got any important interactions. We'll start them on 20 milligrams of atorvastatin. And we can see that it's now running a protocol, a safety protocol, to say, have you done, is this safe? Are you doing the right thing? So it's first checking that I've done the appropriate monitoring tests to start with. And then it's warning me, you haven't set a cholesterol target. So do you want to set the target? Yes, I do. It's just warning me that this cholesterol result looks a bit old. Is that okay to use it? Yes, it is. And then it's telling me what the cholesterol target is going to be and allowing me to record that. And then it's asking me to complete a lipid lowering checklist. And if I can just move to that screen. So what this is doing is ensuring that I give the patient the correct information about this medication and record that, and I've got it recorded in the record. And if I need to, I can open up this patient information leaflet and print that out for the patient. So we can then see that that information is recorded and easy to find to make sure that we've done that. I can then set up a task that will send a task in 3 months' time to remind the practice to recall the patient for lipid check and monitoring of the LFTs. So if we take the next patient, so we can see this patient also looks like they're eligible for primary prevention. They had a Q risk above 10 quite a few years ago. And we can see that they're supposed to be on simvastatin 40 milligrams, but there's a warning here saying this patient doesn't seem to be taking their medication. So we can use the medication timeline to have a look at actually what is the patient taking, and we can see, yes, actually there's only been a few issues of the statin over the last year or so. And we could also follow through over a longer time what's been going on. So we can see originally started on atorvastatin, but only took that very briefly, and then onto simvastatin and really isn't taking that very much at all. That would also be built into the medication review. So if you record a medication review for this patient, you can see it's flashing up this warning again, as well as some other issues that the patient might have, such as stop issues or anticholinergic burden score. If we take this patient, so we can see again, this patient's likely to need primary prevention. We can get more details on that if we like. And we can see actually this patient's got high cardiovascular risk and significant chronic kidney disease. And we can see the cholesterol levels are pretty low. And we can see the patient is on simvastatin, and we're being warned at the moment that the statin dose actually might be too high. You can see there's no target cholesterol recorded here, and we can't really calculate the target cholesterol based on the most recent non-HDL because that's a treatment one. So there's a place where we can go back and have a look to see, well, what was the target for this person? We can see, let's take October 2010. We can see that the non-HDL cholesterol then was 5.8 minus 1. So we can pop that into the system. So 4.8 on the 25th of October 2010. And then there's a quick link to a calculator where we can quickly record or calculate the target cholesterol, which is basically less than 2.9. So that's now recorded in the system. We can see the patients easily achieving that. And we could go through to have a look at the concerns, and we can see, you know, that we should possibly be avoiding doses of simvastatin at that level for patients whose eGFR is is less than 30, and that may be that we need to seek some advice from renal colleagues. If we take this patient, so for this patient, he's got existing atherosclerosis. It's warning us that maybe we need to be thinking about screening this patient for familial hypercholesterolemia. So we can do that on the FH screening template. So what this allows us to do is to calculate a Dutch clinic lipid network score, and it's showing us the information from the record which might be relevant. So we can see that there's a record of premature family history of ischemic heart disease, and there's no obvious record in the recorded of a family history of high lipids. We haven't got a record of some of the cutaneous manifestations of FH. You can see when his earliest diagnosis of atherosclerosis was, and we can have a look back at the lipid results. Or we can get even more detail of the lipid results going back over a long period of time. We can then use that information to calculate the score. To help us make a decision as to whether or not we need to refer the patient. And we've also got the option here to look at potential secondary causes of dyslipidemia, like alcohol consumption and weight and diabetes and so on. So I'm just going to move to another patient. So for this patient, the you can see existing atherosclerosis. We can see pretty poorly controlled lipid results. Not currently on any lipid medication, and we can see a warning suggesting perhaps we should be thinking about referring this person for a PCSK9 inhibitor. So we can click through to the information about PCSK9 inhibitors, and we can try and have a look as to whether that might be appropriate. So we can have a look back through the lipid results and see that the lipids have been poorly controlled really for quite some time. We can have a look to see what medications already been tried. So we can see a very large number of medicines have already been tried, and we can actually follow through to see when they were tried and what effect they had. And then we can see, yes, there's a significant number of adverse reactions recorded to a number of medicines. So, and also that there's no clear record of lipid clinic involvement. So this would look like the sort of person who might well be appropriate to offer referral for considering PCSK9 inhibitors. What we can also demonstrate in the system is how this lipid management links into everything else. So this person's also got diabetes. So on the diabetes template, we can see the lipid results are here. We can see what the target is, although she doesn't have one recorded. And again, we can see that lipid therapy would normally be recommended, but the patient isn't on any, and perhaps we should be thinking about referral for PCSK9 inhibitor. And we can again link through into the same place. So I'll just finish with some examples of some of the impact of these sorts of approaches where we're trying to integrate these different interventions, looking at systematic reviews, data quality, looking at opportunistic assessment of patients, and show you the impact on the prevalence of these 4 conditions in our local area. So in Derwentside, in my primary care network, we for the past few years have been running a series of quality improvement schemes, and we're the blue line, the orange line is our neighbours, and the yellow line is the national prevalence. And you can see for all these conditions, atrial fibrillation, diabetes, heart failure and hypertension, we've been getting much better at identifying these patients, and hopefully this shows that this is quite a powerful tool. Thank you very much.